you very much for that very kind introduction. And thank you for the opportunity to speak today. I apologize. I'm in the Dominican Republic. The Wi-Fi might be a little unstable. So if it drops out, I apologize. Steve's got my WhatsApp. So if there's any issues, Steve, let me know. And also thank you for letting me go before Dr. Kevin Walsh, because he's much smarter and more experienced than me. So I wouldn't want to follow him because he'd make me look silly. So I appreciate that I get to go first. So hopefully you can all see my slides. Let me know if you can't. So I thought I would just go through the case example that was actually the first use of the MFO in North America. And it wasn't a straightforward case. So I think it's a really great case to highlight the great device that is the MFO. We'll also go through what's currently happening in North America and just give a quick one slide rundown of where we're at with trying to get FDA approval, as I think anyone on this call will know that we all believe in this device and we all want it available for our patients. So first of all, I thought I'd just go through the device itself. This is the device, as you can see. It's a self-expandable nitinol frame. The smaller devices, the 5.3 through to the 8.6, they don't have a membrane. You can see there, it's just the frame itself. It has two hubs, and that's a huge advantage of this device. So you can deploy it from either a left ventricular approach or a right ventricular approach, depending on what your concerns are and where the defect is and what's going to be the easiest path through. And there's two discs are connected by a cone-shaped waist and a small little connection between the two retention discs on each end. It's a double disc device, and as we said, nitinol wire mesh. And then in the larger devices, there's actually and that's the 9.7 to the 14.12. You'll actually see there is a PTFE membrane that's sewn inside those devices, and that just helps with stopping residual shunt and allowing for endothelialization to occur quicker in those larger devices. And as you can see here, it's a very flexible and malleable device. So you can see that little connection between the right ventricular retention disc and the left part of the device, which has the waist on it. And that really allows for a lot of flexibility. And you'll see that in the case example as I go through. And on the bottom right here, you'll see that it can go anywhere from 4 to 7 millimeters and really stretches out and flexible. And that, I think, is a huge advantage of this device, that rather than forcing a pressure onto the myocardium, it will actually move with the contraction of the heart. And I think that's one of the reasons that we have this reduced risk of AV block with this device, because it's not a stiff device rubbing up against and causing inflammation and irritating the myocardium. And the soft braided mesh, really, it's very conformable, and it's a great device. And so that, allows us, and with this double retention disc with the two, double-sided screw, allows us for that retrograde or antegrade approach. And again, I'll show the advantage of that. So this is just some of the measurements of the device, easily found from the company. But like most devices, there's, the larger waist, for the smallest device being the 5 millimeter, the smaller waist being the 3, hence how they name it a 5.3. And then the retention discs have an extra 5 millimeters on top. And that just allows, for it to be able to capture in the myocardium. And obviously it's good to know how much extra, because you need to plan that when you're looking at whether you have a small rim under the aortic valve, and where your device is going to be placed in the septum. These are just some features of each of the devices, and just comparing to a couple of other devices that are on the market. Mostly the AD02, which has gained a lot of momentum in the VSD space. I think more of them put in for VSD than there is for ducts. So as I've already gone through, it's soft, so it's highly conformable, reducing damage to tissue and AV block. That thin waist, less residual shunt, allows for full occlusion. The double-sided screw, again, allowing you to change your approach. Really useful for the smaller babies when you're trying to go maybe through a PFO and etc., being able to change your delivery side. Also reducing the amount of TR and AI that you would get with the previous devices. Low profile, so in the smaller devices for the small children. It goes through a 4 French. The larger devices go up to a 7 French. Again, you're not putting them in small babies, so good delivery sheath profile. And this elongatable waist that we've talked about. So what we know so far, having looked at all of the evidence that is out there, that this device, when used appropriately, has a much lower complication rate than other devices. And that's because previously with other devices, you would come from the right, you'd form a loop through from the left ventricle into the PA, and then you deploy it from the right ventricular. You come through, deploy the left ventricular side first, and then put the rest of the device in the right ventricle. And often you'd have TR with that. And you weren't sure whether it was from the device or from the delivery system that was stiff. And so it would be released, and then there'd be, in somewhere around 5% of cases, there'd be significant TR afterwards. Well, the advantage of this device is that you can come the other way, not have to make a rail, push your sheath through from the left ventricle into the right ventricle, and deploy that right ventricular disc first. And whilst doing this, you can assess the TR under echo. And if you don't have any TR, then you haven't caught any of the chord tissue, any of the valve tissue, and that means you're not going to have TR moving forward. If you do see TR, you recapture the device, change your approach, and redeploy the device. And same thing with the aortic incompetency. If you have a small aortic rim, then you can try coming from the other way. But also, I've done a few where it's close to the aorta. You can see that the device will move itself away from the valve, and so you can still deploy it that way. But again, being so malleable and flexible, we're seeing less AI. Heart block is a huge thing that here, especially in the US, where the previous Amplatzer device was taken off the market because of the amount of complete heart block, and that really put VSD closure backwards a lot here in the US. This device, as far as we're aware, out of over 2,000 implants, has had one patient that was said to have complete heart block, but on review of the case, the patient actually was in heart block before they even put the device in. They're in heart block just from pushing the catheter and wire through. And I think that from the experience that people have from Asia, that if you see a new bundle branch block or complete heart block with the wire, then that device is going to give you a much higher chance of causing heart block, especially if you're already in heart block, and it will sustain that way. I think over time, we'll probably find that those patients were ones that probably would have got heart block from surgery anyway, or would have a higher risk of that. So over time, we might find that that cases like that might just have to happen, because it's better than having a large VSD remaining. But for those of us in the US, we obviously wouldn't go ahead with a case where we saw any chance of heart block. Smaller sheath, less access complications. Overall, it's a very good device, low complication profile when used in its appropriate way. So I'll go through the case that I first used it for. This was a 4-year-old girl who was 15 kilograms, and she had a background of trisomy 21 with a complete AVSD. She had repair at 8 months old and was left with a residual VSD, which turned out to be VSDs, with severe left AV valve regurg and moderate right AV valve regurg. She'd been quite symptomatic with increasing work of breathing, decreasing exercise tolerance, and her cardiologist sent her just for a diagnostic cath to assess for possible surgical valve repair. And so this was her echo. So you can see there's a really large VSD there right under the aortic valve in what you would probably describe as a perimembranous position, but this is a post-op AV canal. So it's really not a perimembranous defect that you would be normally to, but perimembranous membrane tissue around it. You can see how much right and left AV valve regurg there is as well. And again, he's just profiling that VSD better, how it comes up over the top of the patch right under the aortic valve, and coming through, as I said, into what would be more of a perimembranous type position. Her hemodynamics showed that she had a QPQS of 1.6 to 1, and that's under anesthesia, so probably higher when she's more excited. So I just went off to Malaysia and got some experience with the MFO. and spoke to the team there. And I thought maybe we could close these VSDs and allow her to grow more before she would need a valve repair or replacement. So we got the compassionate use in the US and we went ahead with the case. And here's just some more pictures of this day, May 1st, 2020, where we're doing this procedure. So again, we're just profiling it, and you can really see how it comes right up underneath over the top of that patch there. Quite a difficult spot for the surgeon to be able to get to. So this was our angiogram that we did. And as you can see, there was not just one defect, but there was two. There was one that was coming from lower down in the mid septum, and one that was coming up around the patch in that, sort of perimembranous position. So we went ahead and we decided we close the lower defect first. So we crossed that with our wire and then put our sheath through. And because we were coming from the aortic side, we didn't have to form a rail. We just pushed the wire through and then followed that with the sheath. And here you can see the device in the under echo here, very echo bright device as we're pulling that back onto the septum. And here under angiography, you can see that the disc, because it's so flexible, you can really tell when you're up against the septum. So we deployed the rest of that device, and this is what I mean by how flexible it is. You can see the device is being pulled up really high by the sheath and delivery catheter, but that's totally fine in this case. This device just will easily drop down into position. And you can see on echo now, there's no further shunt that we can see around that device. So we released the device after we did some angiography just to confirm that it was in a nice position. And if you keep your eye on the release on the right of the screen, you'll see just how much that drops and reforms itself. And I think the other thing I really love about this device, when you're watching it, you can actually see how, as the heart's beating and the myocardium's getting thicker and thinner, that the device is really bending and allowing the heart to pump without there being any real force on the device. So we repeated our angiogram after we put that device in. You can see we've closed off that first shunt. It's got a nice waist on it. And now we're going to go after that top defect. Now, because of the angle that this device was coming off and how it came up underneath and over the patch, we were unable to get across with your standard methods of a JR catheter. So I used the pigtail. It was an interesting technique, but I used that with a coronary wire to form a little loop up to the aortic valve. And as it came back, let it flick into the defect and push the wire through. And you'll see there as it goes across that defect. And then, formed a rail with that, just because of the angle that we're going to have to go at to get our sheath across. So you can see up on the top right where we've got our device all the way through, forming a rail. And so here we've gone again from the aortic approach, put it across, deployed the right disc out in the right atrium and pulled it back across. And under echo, there was no TR, so we're good to go ahead. We could see there was a little tiny little part of shunt that was right next to this device that we just couldn't capture, but it was too small for a device to go in. So we were hopeful that over time it would disappear, but we felt that we'd covered the majority of the larger part of that defect. So again, looking at this device, how it's pulled up, you could be worried that, maybe that will be too close to the aortic valve. But this device, as I said, you got to look at the angle that the right disc compared to the waist of the left disc is, because that's how your device is going to settle. It's not going to stay in this position. And then sure enough, if you keep an eye on here as we deploy it, we can see that little residual shunt, but the shunt is reduced dramatically. And as the device deploys, you'll see it just change dramatically its angle. So it dropped down a good couple of millimeters there as we pull the sheath away, a really big drop. And this was what the devices were like afterwards. And as I said, you can really see how the discs are being pulled apart and really flexible under the contraction of the myocardium. And on echo, really great result. No, one tiny little residual defect, as we said, that was just impossible to get to, but a little bit of flow through the device at this point in time. And we see that, but by 1 month they had closed up. And at last follow-up, she was asymptomatic now and thriving. This is 2 years on and she still hasn't had surgery for her AV valves. So I think a really great victory, a complex case, but it shows just how malleable this device is. So now, so far in North America, we've had 4 cases that we've attempted with 3 successes. The one failure was a 3 kilogram post-op VSD and it was a bit of a Hail Mary because the surgeon was not happy to go back in this child. The child was very sick. We were just unable to get the sheath and device in position without causing a lot of hemodynamic instability. So we had to abandon that case. So far in Canada, the device has been approved through the Special Access Batch Release, which allows for devices to be deployed under the watchful eye of the Canadian regulatory boards. But so far, they've had 16 successful implants. They've got 7 scheduled in the coming months. One of those patients was an Ebstein's anomaly, which we believe is the first time that this device has been used in Ebstein's anomaly, and that was a successful implant. Again, no major complications, and all devices post 1 month have got no residual flow. So doing really well with the implanting over here in North America. Where we're headed in the US will be, we're in the process of getting an FDA IDE device study. So we're going to look at the MFO as a non-inferiority study to show its benefits. We hope to get 50 patients initially over 5 to 8 sites, and hopefully within 2 years, we'll have full FDA approval for that device. I'm going to be the PI for that FDA study, and we're doing this through the Medical College of Wisconsin. So it's a big project that we're undertaking, and couldn't do it without the support of Lifetech. And I want to thank you all for listening. Thank you for your time. And if there's any questions about the case or anything else about the device, please go ahead.
Thank you, Dr. Daniel. Excellent talk and interesting case sharing. Any question or comment from the audience?
Daniel, Kevin Walsh, can I ask you just a question about the pigtail coronary wire technique you used to cross the defect? I mean, it produced a nice sort of horizontal, sort of subaortic trajectory for the coronary wire. Did you snare that? Did you snare that wire afterwards, or were you able to put it to upsize it for the 3.5 wire, or what did you do?
Yeah, so what I did was I snared the wire. So I got the wire through. It was only, as you could say, it was only a coronary wire. So I put it through, snared it, and just by snaring it, it was enough for me to be able to get the delivery sheath through, because the delivery sheath is quite flexible, and it was enough for me to get that through. So I didn't have to exchange the wire. I just formed a rail and then used the delivery sheath from the aortic side to do it. Once it was through and straightened out, it was a pretty straight course for that delivery catheter, but it was just impossible to cross it, with any other catheter to get that wire across. So.
Did you snare it in the atrium or IVC or SVC or
PA? Snared it up in the PA. I managed to get it to go out to the PA. Snared it up in the PA, and then pulled that down to form the rail. And once it was a straight rail, like I said, it was a really easy to get that sheath across. It's quite a hydrophilic sheath and quite flexible, so it's able to traverse the course quite easily. And then I pushed the sheath right out down into the IVC for deploying the device. So.
Okay, before you came back.
Sorry, Kim, I missed that last comment.
Sorry, you said you took the delivery sheath all the way into the IVC before you introduced the device.
Yeah, before putting so I pushed the device through the sheath all the way in the IVC, and then pulled out the right ventricular disc in the IVC and pulled it back through the tricuspid valve. I just, I've had sometimes in the atrium where you as you're trying to deploy that, your catheter can sort of kick you back into the ventricle as you're trying to deploy the right disc. So sometimes if I can just put it out a little bit further, just to make sure that as I'm deploying that disc, I'm going to be able to pull that through the tricuspid valve without capturing the valve. So.
Okay, very good. No, thanks for that excellent case.
Daniel, why you use the retrograde deployment and not the antegrade deployment?
Well, that's what I think is the advantage of this device, is that, one of the major complications, as I said, from early device implant is tricuspid regurg from impingement of the device when deploying from when you deploy the left ventricular disc first, and then you're pulling out the right disc. Because obviously when you're doing that, you're pulling back on the sheath, and as your device comes out, it can easily catch chordae tissue or valve tissue. So I've felt that the great thing with this device is whether you're worried more about aortic regurgitation or tricuspid regurgitation is how you should deploy your device. So with these two defects, I was not concerned about aortic regurgitation. I felt there was enough waste, and I felt the angle of the two defects would not interfere with the aortic valve. So I was more worried about causing tricuspid regurg in a patient who already had, pretty bad tricuspid regurg. And so, under echo, I was able to see that there was no change in the tricuspid regurg, or no worsening of tricuspid regurg. So I felt confident that would be a better approach. I think in some of the true perimembranous defects, you can often have, only a 1 or 2 millimeter rim under the aortic valve. And in those cases, I think you have to be very careful of causing aortic incompetency. And so in those cases, I might come from the different approach and deploy that left disc first. So really, you just have to, when you get used to the device, decide what you think is going to be a higher risk, tricuspid regurgitation or aortic regurgitation, and deploy in the way to minimize that risk.
I agree with you. If the perimembranous VSD with long aneurysm formation, if I deploy anti-gravity, probably the elongated right disc will influence the tricuspid valve. So if I want to avoid the damage of the tricuspid valve, I will deploy it retrogradely.
Yep, agree totally. It's, and that, as you alluded to, comes from experience with other devices and with this device. But I think that's one of the great benefits, is that you have that choice. You can do it so that you can reduce the chance of making things worse. And I think that's especially in North America, maybe not so much in Asia, but we're always under the watchful eye of our surgical colleagues. So we need to make sure that we're making this procedure safe, and not giving reasons to be able to not be doing this device deployment. So I think it's a really good point you bring up about the aneurysmal tissue, that when you're deploying that in the standard approach, you can actually end up with worse TR.
Okay, thank you. Dr. Tomita, are you here?